Oh hello! Welcome back to the second student project review by Gede B1. In this student project, we will discuss, next slide, about the topic of anatomical changes of spatial sense in COVID-19 patients. Why? Well, we will get into that later. First of all, let me introduce our group member quickly. Unfortunately, our time is very limited, so in case you want to get the detailed information, you can pause the video in between the slide, but don't worry, because we will introduce ourselves once again right before we deliver our presentation respectively. Next slide. Based on my statement before, you can pause the video right now. And as for the others, you can pause the video right now. And last but not least, you can pause the video once again right now. In which it is myself as the group leader of SGD B1. My name is Gede Saputra and my NIM number is 2102511118. For now, let's move on to the presentation. Next slide. Thank you. To make it easier both for us to explain and for you guys to understand, we decided to divide this review into three parts. The first part is the introduction, where we will discuss what is this project's background information, problem formulation, goals, and objectives. Then the second part is where the content is. As the title of our project stated, we will discuss the changes, signs, treatment, risk factors, and even the prevention of COVID-19 complications on each of our special sense, starting from our eye, ear, nose, tongue, and up to our skin. Finally, the third and final part in our student project is our summary and suggestion regarding this project. Next slide, please. Okay, if you guys remember, in the beginning I asked why we chose this topic. In the first session, I will explain the background information of our student project and then continued by my colleagues reviewing the rest of the presentation systematically. So be sure to watch the video until the end to get a better view of COVID-19 and its complications, especially on the 5 special sense. Next slide, please. Okay, as we know, the whole world has been put into a temporary shutdown phase these past 2 years because of certain virus outbreak in Wuhan city of China on the 31st of December 2019. This virus, quickly identified as SARS-CoV-2 due to 70% of its genome is similar with the first SARS-CoV virus, and it is believed to came from bats. The first case of COVID-19 in Indonesia was reported on the 3rd of March 2020 when 2 Indonesians had contact with affected Japanese people during their stay. And as of 20th of October 2021, in Indonesia alone, there are 4,237,201 confirmed cases, with 143,077 of them have died. Based on that, COVID-19 is a concerning disease in which, if left untreated, will cause many complications that might even lead to death. So these complications include both physiological changes and anatomical changes on our body. Next slide, please. Okay, then there are the 5 special sense, the most important information receptor in our body, in which from them came all of the sensory impulse that make it possible for us to even feel the entire world. But sadly, they're also one of the most susceptible organs to be affected by COVID-19 virus. With that said, the information of public health information systems during the COVID-19 outbreak cannot be overlooked. It is very important. We not only fight the virus, but we also have to fight the lack of information and misinformation. This is where the trouble begins though. Because Indonesia, unfortunately, seems to unable to provide said things efficiently for the people. Limited amount of data and lack of consistency, while hoax is still being spread by the media, might just be the cause of fear and mistrust from the general public towards the government. That is why we wrote this project in the goal of informing the public about the concerning topic of COVID-19 complications, especially in the 5 special sense, regarding on how to identify, treat, and even prevent said things. Based on the previous background information. Next slide, please. Okay, thank you. we formulate the main problem that we will try to solve, which is what is the anatomical alterations on the COVID-19 patient's special sense. From this main problem, we can derive 5 questions, which the first one is, what are the anatomical alterations on the COVID-19 patient's vision? Second one is, what are the anatomical alterations on the COVID-19 patient's auditions? The third one is, what are the anatomical alterations on the COVID-19 patient's olfactions? The fourth one is, what are the anatomical alterations on the COVID-19 patient's gustation? And the final one is, what are the anatomical alterations on the COVID-19 patient's somatosensation? Next slide, please. Okay, also based on the previous said background informations, the objectives of our research can be classified as general and specific objectives. Next slide. The general objectives is to inform the general public about the chronic complications of COVID-19, while there are a total of 5 specific objectives from our project. Next slide, please. Okay, which is, the first one is to describe the anatomical alterations on the patient's vision due to COVID-19. The second one is to describe anatomical alterations on the patient's audition due to COVID-19. The third one is to describe anatomical alterations on the patient's olfaction due to COVID-19. The fourth one is to describe anatomical alterations on the patient's gustations due to COVID-19. Then the last one is to describe anatomical alterations on the patient's somatosensation due to COVID-19. Next slide. The benefit of our research is we can show and learn the clinical science regarding our topic, which is the anatomical changes in COVID-19 patients, especially in the 5 special sense, from various credible sources. And then we can also see if something needs to be improved or studied further. We can also help the improvement of medicine regarding the COVID-19 complication, especially on the 5 special sense. And then final one is we can help undergraduate students to learn about the clinical knowledge required as a medical professional.
Hello, my name is Adjani Sayidina with the last number 031, and I will explain about the anatomy of the eye. The human eye is a light-sensitive organ that provides vision. Photoreceptor cells in the retina, such as rod and cone cells, can detect visible light and transmit this information to the brain. The eye consists of the eye socket or the orbit and the eyeballs. The orbit is a pyramidal cavity in the facial skeleton that is anterior and its apex is posterior. A bulbous oculus protects each orbit, as well as muscles, nerves, and arteries, as well as practically all of the tear system. Periosteum lines the bones that make up the orbital cavity. The orbit contains the eyelids and lacrimal apparatus. The eyelids keep the cornea wet and protects the eye from damage. These folds are movable, with thin skin on the exterior and the palpable conjunctiva on the inside. The lacrimal apparatus comprises the following parts: glands, ducts, canaliculi, and fornix. Lacrimal fluid is excreted by 8 to 12 excretory ducts that open into the conjunctival sac. A film of fluid is pushed medially over the cornea when the eyelids come together. There are 3 layers of the eyeballs. The first is sclera and cornea that make up the fibrous layer or the outer coat. Second, the choroid, ciliary body, and iris, which make up the vascular layer or the middle coat. The third is the retina, which has optic and non-visual elements, which is found in the third layer or the inner coat. And our orbital nerves, which are large optic nerves which develop as paired anterior extensions of the forebrain, are exclusively sensory nerves that convey impulses generated by optical inputs. And lastly the vascularization of the orbit. The orbit's arteries are supplied by the ophthalmic artery, a branch of the internal carotid artery. The infraorbital artery receives blood from the external carotid artery and provides the orbital floor and other surrounding regions. The central retinal artery, a branch of the ophthalmic artery that arises inferior to the optic nerves, pierces the optic nerve's dural sheath and travels through the nerve to the eyeball, emerging at the optic disc. The inside surface of the retina is covered with branches of this artery.
Thank you for the opportunity. My name is Putu Isyundra, lastly the number 003. I would like to explain about the anatomical changes of the visionary system in the COVID-19 patients. Diagnostic and therapeutic efforts of COVID-19 have been focused on respiratory complications of the disease, while several other implications also emerge. It is reported that clinically, COVID-19 has been associated with mild conjunctivitis. It is also found that subretinal changes like hyperreflective lesions in the inner layers of optical coherence tomography or OCT, convoluted spots, and microhemorrhages. In this opportunity, I will explain more about conjunctivitis in COVID-19 patients. Conjunctivitis was reported as a manifestation of the disease, and viral RNA was found in the patient's tears. The eye surface could potentially serve as a guideway when exposed to aerosol droplets or hand-eye contact. SARS-CoV-2 also can be inoculated through infected tears, which carry the virus through the tear duct into the nasopharynx. The virus may infect the conjunctiva through yet unidentified receptors. Other diseases also found, such as Kawasaki disease, diabetic retinopathy, retinal findings, and neuro-ophthalmological complications. It is also reported that intensive treatment of COVID-19 can develop into ocular complications, such as ocular disease and secondary infections. That's all from me. Thank you.
Let me introduce myself. My name is Gusti Agung Librawan Dharma Laksana with number 21025111029. Okay, I will continue the presentation about the treatment for anatomical changes of the visionary in COVID-19 patient. Several treatment strategies for COVID-19 are currently being investigated, but none of them has been proven safe or effective until now. And among the number of drugs that have shown positive results, the use of hydroxychloroquine and chloroquine has been of concern due to their non-toxic effect on the retina. This is a good development for the medical field, but the risk of the toxicity in short-term use is still not known with certainty.
Thank you for the opportunity. My name is Adjani Sayidina with the last digit number 031, and I will explain about preventions and risk factors of the anatomical changes in the eye. Some ways we can avoid the factors that causes anatomical changes in the eye due to COVID-19. First, to prevent conjunctivitis, there are three ways. First, by reducing touching our eyes with hands, to regularly wash our hands, to always use a clean towel or washcloth. To prevent diabetic retinopathy is to increase physical activities during the lockdown. However, to prevent the other anatomical changes to COVID-19 such as Kawasaki disease, retinal findings, and neuro-ophthalmological complication, there are no clear ways yet, and it is crucial to get treatment if you may experience these symptoms. And now I will explain about the risk factors of these eye complications. These eye complications may occur in any COVID-19 patient, male or female equally, except in Kawasaki disease, which has a slight male dominance, and diabetic retinopathy, which has a slight female dominance. These eye complications may occur at any age, except in Kawasaki disease, in which children are dominant, and diabetic retinopathy at the average age for this disease is 59.5 years old. These eye complications are closely connected to illness severity and affect individuals early in a disease cycle. Risk factors exclusive for conjunctivitis are old age, living in congested location, chronic lung diseases, comorbidities such as immunocompromised states, diabetes, obesity, chronic renal and liver disease. Healthcare professionals are at a high risk of contracting the virus. Direct contact with a person who has COVID-19 is a risk factor for COVID-19 related conjunctivitis. Previous research also showed that the virus could be transmitted through the eye.
So hi everyone, my name is Khadra Kamila with the last 3 digits number 009. I would like to explain about the anatomy of the ear. Ears are one of the special senses that humans have, and the ear is the organ that is responsible for hearing and balance. The human ear is divided into 3 parts. They are external parts, middle parts, and the internal part. The outer of ear consists of the auricle and the external auditory tube. The auricle is covered by a thin skin and it's composed of elastic cartilage. The auricle has several elevations and depressions called the concha of the auricle. The upper margin of the auricle is known as the helix. The auricle also has part called the lobule of the auricle. It is a non-cartilaginous part composed of blood vessels, fibrous tissue, and fat. The next part of the auricle is the tragus, which is the opening part of the external acoustic meatus, which is also the part shaped like a tongue. The tympanic membrane is the organ that separates the outer ear from the middle ear. The tympanic membrane is divided into two parts, the tympanic cavity proper and the epitympanic recess. The section called the pharyngotympanic tube is the connection between the middle ear to the nasopharynx. The middle ear comprises ossicles. These three interconnected small bones are known as the malleus, incus, and stapes, respectively. There is also an eustachian tube in the middle ear, which is also the canal that connects the middle ear to the back of the nose. There are also tensor tympani muscle and spadius, which the branches of the CN7, namely chorda tympani nerve, and tympanic plexus of nerves in the middle ear. The inner ear is the part that contains the vestibulocochlear organ. Ducts and sacs of the membranous labyrinth are also present in the inner part of the ear. In addition, the inner part of the ear consists of the bony labyrinth. Inside the cochlea, there is also the auditory nerve, while inside the vestibule and the semicircular canals are receptors that play a role in maintaining balance. The nerves in the part of the ear are the vestibular nerve, facial nerve, cochlear nerve, and vestibulocochlear nerve, which pass through the internal acoustic meatus opening. That's all from me, thank you.
First, let me introduce myself. My name is Danissa Putri Dita with last digit number 005. I will presentate about anatomical change of auditory system that caused by COVID-19. According to the current research, COVID-19 can be transmitted to the auditory system through a eustachian tube and affecting auditory nerve, organ corti, stria fascicularis, spiral ganglion, or cochlear, causing auditory disturbance. Besides the virus, COVID-19 patients also can experience auditory disturbance due to some medication effect. A 60-year-old man that was confirmed with COVID-19 experienced deafness with loud tinnitus after recovering from COVID-19. MRI scan show inflammatory process on the cochlea. After doing some clinical tests, it is reported that the man received some medication with ototoxic effects such as azithromycin. That's all for me. Thank you.
Okay, I will continue the presentation about the treatment for anatomical changes of the auditory in COVID-19 patient. The hearing loss patient with COVID-19 tend to sudden sensorineural hearing loss or SSNHL and tinnitus. Treatment that can be done for patients with experienced sudden sensorineural hearing loss can be in the form of conservative therapy, one of which is the administration of corticosteroid in two ways, namely local and systemic. Local corticosteroid therapy is therapy given as primary therapy, salvage therapy, and combination therapy. This therapy can also be done by injection intratympanic directly. For patients who fail to receive systemic corticosteroid therapy, intratympanic corticosteroid therapy is a salvage therapy that can be an option. Intratympanic corticosteroid therapy is the most commonly used therapy for sensorineural deaf patients, although the effectiveness has not been definitely proven. Intratympanic corticosteroid therapy consists of several protocols, which is primary therapy, adjuvant therapy, and salvage therapy. The treatment that can be given to people with tinnitus depend on what is causing it. Tinnitus caused by side effect of the drugs that the patient is taking. It can be treated by changing the type of medication. Several therapies can be carried out by patients with tinnitus, namely therapy using sounds. It can discuss ringing in the ears, such as the sound of waves or rain, and perform tinnitus retraining therapy or TRT. In addition, COVID-19 patients who experience tinnitus can perform cognitive behavioral therapy or CBT. This therapy aims to prevent a bad mental condition due to tinnitus to improve the patient's quality of life.
I would like to explain about the prevention of anatomical changes in auditory system. So, based on a case that has been explained before, we can find a link between the COVID-19 and audiology disturbance. COVID-19 can cause the variety of audiological problems, starting from tinnitus until SSNHL. Problems can occur on patient as symptoms or post-recovery side effect, and it's not handled quickly and properly yet. To prevent COVID-19 patients' audiological problems worsens, the doctor can prevent using medication that will lead to ototoxicity. These medications used to treat the COVID-19 patients such as azithromycin, quinine, and chloroquine, and etc. that have been widely promoted during the pandemic. Side effects based on the past data commonly caused by ototoxicity drugs are sensorineural hearing loss, tinnitus, and persistent imbalance. Ototoxicity can cause the severity of hearing loss, tinnitus, or imbalance influenced by the dose. Using corticosteroid is the other way of treatment that is not recommended by World Health Organization because it can increase the risk of severe infections. Being aware of non-specific symptoms is crucial in this pandemic era. It can help prevent the spread of the virus and help the patients who suffered auditory disturbance get early treatment, so it's not going to be worsened. Thank you, that's all from me.
I will presentate some risk factors that can increase the risk of COVID-19 patient experience auditory disturbance. First, low oxygen or ischemia that experienced by most of the patient can be the cause of auditory problem due to the patient inner ear not getting enough oxygen. Second, SARS-CoV-2 can invade patient inner ear or vestibulocochlear, causing cochleitis or neuritis. Third, patient immune system such as T cell can mistakenly attack patient inner ear cell. Fourth, patient can experience some cytokine storm that will kill patient healthy cell. And lastly, patient could experience auditory problem due to receiving some medication with ototoxic effect, causing hearing loss or tinnitus. That's all from me. Thank you.
My name is Julia Caroline and my last digit number is 016. The nose consists of the external nose, nasal cavities, and paranasal sinuses. The external parts of the nose that can be seen are the dorsum of the nose, root, nares, nasal septum, and apex. The nasal cavity is also divided into olfactory and respiratory areas. The olfactory region is a specialized mucosa that contains the peripheral olfactory organs. The nasal concave divides the nasal cavity into 4 channels: the sphenoethmoidal recess, superior, middle, and inferior nasal meatus. The paranasal sinuses are frontal, ethmoid, sphenoid, and maxilla. The main target of the coronavirus is the human respiratory system. Coronavirus has infected human respiratory epithelial cells and is neuroinvasive and can spread from the respiratory tract to the central nervous system. The olfactory function provides essential information about the environment, so sensory circuits are dedicated to olfactory processing and multisensory integration. Inflammation of the local epithelium can block the olfactory cleft. Support cell infections lead to local increases in inflammatory intermediates such as cytokines, which affect olfactory sensory neuron function. MRI studies have revealed temporary changes in the olfactory bulb associated with anosmia. Image A shows before the diagnosis and image B shows after the diagnosis of COVID-19. Look at the size change, namely the olfactory bulb that shrinks in the olfactory groove that indicated by the yellow arrow, and the figure also shows an increase in CSF, which is indicated by the blue arrow. Thank you.
Hi, my name is Nyoman Gede Sujana with the last 3 digits of NIM number 011. Loss of olfactory functions related to the COVID-19 virus is assumed to be due to the direct damage of the olfactory system. The process of infections of the SARS-CoV-2 virus begins by utilizing ACE2 that are found on the cell surface as a binding receptor assisted by TMPRSS2. After that, the viral RNA enters the cell's nucleus, replicates, and spreads to each cell. It's causing an inflammatory and demyelinating reactions, causing olfactory dysfunction so that manifestations of loss of sense of smell occur. Several studies have shown that SARS-CoV-2 can attack peripheral nerves, spread along the nerve synapses, and enter the CNS through the olfactory neural transport, or we call as transsynaptic transfer of the virus. The first mechanism is through infections and binding transport across vascular endothelial cells. The second mechanism is through leukocyte infections that pass through the BBB, or called the Trojan horse mechanism.
Okay, I will continue the presentation about the treatment for anatomical changes of the olfactory in COVID-19 patient. When COVID-19 related olfactory dysfunction improves spontaneously, specific treatment may not be required. But treatment of post-infectious olfactory dysfunction may potentially be helpful for the COVID-19 patient. First is olfactory training, or OT. Olfactory training involves repeated and deliberate sniffing of a set of odorants for 20 seconds, each at least twice a day, for at least 3 months. Studies have proven improved olfaction in patients with post-infectious olfactory dysfunction after doing olfactory training. Olfactory training is considered being able to train the brain to correctly interpret the neurological signal. Second is medication in post-infectious olfactory dysfunction. Medication promising in post-infectious olfactory dysfunction include intranasal sodium citrate, which modulate olfactory receptor transduction cascade, systemic omega-3, which may act through anti-inflammatory means or neuroregenerative, and intranasal vitamin A, which may act to increase olfactory neurogenesis.
Preventions. There are some ways that can be used to avoid the cause of anosmia, but one important prevention that we must remember is doing the protocols of COVID-19 everywhere and every time. Risk factors. Risk factors for anosmia were gender, loss of smell history and poor olfactory self-reception for detections, education level, pregnancy, age, history of the head trauma, smoking, and exposure to noxious substances. That's all from me, thank you.
My name is Putu Krishna Arsawardani Putri with last 3-digit number 027, and I will explain about the anatomy of the tongue. The tongue is an organ that is mainly composed of muscle. The tongue can be divided into 3 parts: the root, body, and apex. It has a dorsal surface and ventral surface. Anterior and posterior part of the tongue is divided by a V-shaped groove called sulcus terminalis. The tongue is covered by mucous membrane. The mucous membrane on the dorsal surface is rough because it is covered by lingual papilla, which comprises of palate, foliate, filiform, and fungiform papilla. The tongue has 2 types of muscle, intrinsic and extrinsic. The intrinsic muscles control the shape of the tongue, and the extrinsic muscles control its movement and position. The intrinsic muscles lie entirely within the tongue and are not attached to bones, while the extrinsic muscles are attached to bones and other structures outside of the tongue. The hypoglossal nerves provides motor innervation to all tongue's muscles except for palatoglossus, which is innervated by vagus nerve. Sensory innervation of the anterior tongue is provided by the trigeminal nerve and facial nerve, while the posterior part is innervated by the glossopharyngeal nerve.
Hello, my name is Devi Prastiti with number 028, and I would like to tell about anatomical and histological changes in gustatory system. There are still a few analyses of oral lesions associated with COVID-19, so a report has been conducted in Bari Hospital on COVID-19 patients that display oral lesions. The first one is ulcer. These lesions are mainly positioned on the tongue, lip, cheek, and also palate. And if involved with the dry side of the lips, they derive into crust. Second one is petechiae. Petechiae is mostly asymptomatic. It is located on the soft palate and tongue. Presenting with oropharyngeal lesions also appear as mucosal petechiae. Third one, blister. It could be seen on the tongue and palate and suddenly turn into superficial ulcer with the sensation of pain and low bleeding. The fourth one, candidiasis. It could be seen as red forms on the tongue or white forms on the palate. Patients with candidiasis on the tongue mainly get the sensation of overall burning and severe pain. The last one is taste disorder. These disorders are found in more than 80% of COVID-19 patients, with the papilla on the dorsal and lateral side of the tongue appear red-colored along with size enlargement. Histological change could also be found, where in ulcer lesions, epithelial cells are not present, while in the subepithelial tissue, it denotes outstanding vascular hyperplasia, also perivascular hemorrhage. Other lesions such as edema, leukocytosis, and activated Langerhans cells are also found. In petechial lesions, inflammatory infiltrates and focal necrosis hemorrhage were also present in the lamina propria. Thank you.
Okay, I will continue the presentation about the treatment for anatomical changes of the gustatory in COVID-19 patient. First, in severe SARS-CoV-2 infection, it can cause the release of many cytokines from the body, which is a syndrome that can cause other syndromes that affect the respiratory tract. Some treatment, such as immunosuppression, can be given as drug to eliminate the excessive cytokine response, which is inflammation in the host. The medication generates delayed body response to virus eradication, but it is alternative treatment to eliminate inflammatory response are urgent. Second, there are more effective alternative treatment for it. Sohelivar and colleagues have found that the effect of COVID-19 can be determined by using PBMT or photobiomodulation therapy, which are effective treatment for SARS-CoV-2 associated oral lesion. Photobiomodulation therapy is one of modality alternative therapy that has the advantage of increasing a patient's condition by reducing the effect of oral lesion associated with its previous treatment.
To prevent oral lesions to appear in COVID-19 patients, doctors and professionals should take preventive measurement by consultation and facilitating patients in the clinical care team. Besides the medical team, patients of COVID-19 should also still do full mouth physical examination and implement oral hygiene. Thank you.
The risk factor for gustatory dysfunction in COVID-19 patients are age, sex, allergy, smoking habits, and comorbidity. The risk for gustatory dysfunction is higher in people above the age of 60 and slightly higher in female. Current smoking habit and history of allergy, particularly respiratory, significantly increase the risk of taste loss in COVID-19 patients. Hospitalization and comorbidity, on the other hand, have an inverse association with the risk of gustatory dysfunction, suggesting that gustatory dysfunction may be symptoms of less severe COVID-19 infection.
Okay, I will continue the presentation about the anatomy of the skin. Skin is the largest organ of the human body, one of the finest health quality measures since it is easily accessible. The skin consists of two basic layers, the epidermis layer and the dermis layer. The epidermis layer is the most outer layer of skin. It is a keratinized stratified squamous epithelium. The most common cell type of the epidermis is the keratinocyte. There are 4 epidermal layers indicating the maturation of keratinocytes from the deep to the superficial layers of the epidermis. The first one is stratum basal, the next layer is stratum spinosum, the third is stratum granulosum, and the last is stratum corneum. The dermis layer is responsible for general skin thickness variation. It lies between the epidermis and the subcutaneous tissue. The dermis layer is formed by a dense layer of intercalating collagen and elastic fibers forms, and the fibroblast is the primary cell type of the dermal cell.
Thank you for the opportunity. My name is Geg Mas Anantalakshmi with the last 3 digits of NIM number 001. Today, I will explain about the integumentary system anatomical change during the COVID-19 infection and treatment. The first one is urticaria rash. It is characterized by the appearance of wheals and flares. To treat it, we will need a low-dose systemic steroid. The second one is erythematous rash that appears as large reddish patches. To treat it, we will need 0.1 triamcinolone cream. The third one is papullovesicular rash. It is characterized by the appearance of papule and vesicle. To treat it, a wait-and-see approach is recommended. The fourth one is chilblain-like acral pattern. It is characterized by tender lesion on the dorsal part of the body, for example, the finger, toes, ears, and nose. To treat it, a wait-and-see approach can be advised. The fifth one is livedoreticularis-like pattern that appears as net-like cyanotic pattern. To treat it, a wait-and-see approach is recommended, but vasodilator therapy is available for cosmetic reason. The last one is purpuric vasodilatic pattern. It is a non-blanchable purple lesion. To treat it, we will need a mometasone furoate cream or systemic corticosteroid for broader manifestation. The next topic will be explained by my colleague.
Hello everyone, my name is Putu Bintang Pradita Kirana with NIM 21025 11033. So now I'll explain about the prevention and the risk factors. There are 2 types of prevention that can be done. The first one is the personal protective equipment or PPE related damage prevention. It can be done by first, reduce the likelihood of face touching while not wearing PPE or inadvertent PPE protocol damage violation, such as mask touching or adjustment. Second one, at the pressure point where PPE is being equipped, such as at the nose, a bare film wipe or thin foam dressing can be used to prevent PPE-related damage. So the next type is dermatitis from repeated hand washing prevention. It can be done by using alcohol-based cleanser for disinfecting hands. And the next one is to use lukewarm water instead of hot water while washing hands because frequent usage of hot water can lead to skin dryness. And the last one is to avoid water-based moisturizer because it can enhance transepidermal water loss. Next slide please. Thank you. So now we'll explain about the risk factors. So there are some risk factors that can lead to skin changes when exposed to COVID-19. So the first one are damaged skin. So damaged skin conditions like lacerations, scratching, needling, pre-existing infection or illness of the skin may compromise the skin barrier's integrity that allowing for the virus to spread through indirect contact. So the second one, some beauty treatments like ablative laser resurfacing and microneedling. The next risk factors are low humidity, hand washing too frequently, wet work, and length of employment. So those four can affect the skin, especially for hand dermatitis development. So next is PPE usage for a long period of time. So wearing certain medical equipment for more than 6 hours in a daily routine at a higher risk of skin injury than those who wore it for less time. And the last one is immunosuppressive medicines. So immunosuppressive medicines may be linked to an increased risk of opportunistic infection since they weaken the immune system. So I think that's all from me. The next part will be explained by my friends. Thank you.
Thank you for the opportunity. First of all, let me introduce myself. My name is Marvella and my last 3-digit number is 007. Today, I'm going to summarize all of my friends' explanations regarding our student project. So, the conclusion is there are many anatomical alterations of special senses that can be seen in COVID-19 patients. Those changes are on the visionary system, we can see some symptoms such as conjunctivitis, Kawasaki disease, etc. On the auditory system is the damaging impact in the inner ear. On the olfactory system are inflammation and temporary anosmia. In the gustatory system are the rashes. Next, about the suggestion. It is suggested that all societies should follow and apply the health procedure to prevent the virus transmission through the spatial senses. That's all from me. Thank you.